So today we are going to look at the last topic of our series of lectures on basic embryology. The topic is going to be principles of teratology. In this topic, we are going to learn about birth defects. We will begin the lecture by defining a few things. One of the terms I want us to define is teratology. When we talk of teratology, we mean study of birth defects. Don't confuse teratology with tetralogy. So teratology is study of birth defects. The second term I want us to define is teratogen. A teratogen is an agent that causes congenital defects. This agent could be a chemical, it could be an infectious agent, it could be an environmental factor. Whatever it is, as long as it can cause a congenital defect, then it's termed a teratogen. And so perhaps the other thing we need to define is congenital. The term congenital means you are born with it. Now, the term congenital anomaly, therefore, means a structural defect that someone is born with. That means an anomaly is a structural defect, something anatomical. An anatomical abnormality that a baby is born with is called a congenital anomaly. The other term I want us to define is malformation. In most cases, you will use the term congenital anomaly with malformation interchangeably. In its strict definition, the term malformation refers to a primary structural defect resulting from a localized error of morphogenesis, a localized error of development. There was a problem during the developmental process, so that now an organ is malformed, abnormally formed. It simply means abnormal formation. You don't have to bother with the strict definition of the term malformation. Most of the time, you'll be using it interchangeably with the term congenital anomaly, and it is acceptable. But the other term I want us to define is a syndrome. A syndrome is a recognized pattern of abnormalities. Now, they don't have to be structural, but a recognized pattern of abnormalities. Usually, a syndrome will have at least 3 abnormalities that occur together. So in one syndrome, you're going to get at least 3 abnormalities that tend to coexist with some level of prediction. We call that a syndrome. Having defined those terms, let's now revisit what we need to learn. So I'm going to take you through some general principles of teratology. I will also take you through some common mechanisms that lead to causation of birth defects. We will then have an overview of some common morphological defects, which means anatomical abnormalities. I will give you an overview of the causes of birth defects, and we will see later how we can diagnose birth defects even before a child is born. So starting with some general principles regarding teratology, it is important for you to know that about 2 to 3% of live births actually have some form of congenital anomaly. Now that sounds very scary because it means that out of 100 children, about 2 to 3 have a congenital anomaly. To me, that's a high figure, actually. Very high for that matter, and can be very scary. The good news is that even though the prevalence of congenital anomalies is that high, we have a wide spectrum. Most of these congenital anomalies are actually of minor significance or little significance, so to speak. It could just be a very small patch of abnormal color on your skin and nothing much about it. It might be so normal until you just call it a birthmark. It's actually a congenital anomaly. So most of them are very minor, things which may just worry people for aesthetic outcome. But if you're not bothered with that, then nothing much. But a few of them are actually life-threatening. And there are those that are not compatible with life anyway. It's a wide spectrum. Multiple defects can occur within a single individual, and some of these defects may constitute syndromic pictures. I have already defined what syndromes is. So you can have a child with a particular syndrome, and that means that within that particular child, you're going to have multiple defects, at least 3 defects. You may also have just a single defect, not a big deal. Some of these congenital anomalies show geographic as well as ethnic differences. There are those abnormalities that we know tend to happen in a particular population of people. There are those that we know tend to happen in a particular geographical location. For example, the type of malformations that you get, let's say in North Africa, could be different from the type of some malformations that you get maybe in West Africa or something like that. So geographic and ethnic differences have been seen. What are some of the mechanisms that explain congenital anomalies? I'm going to give you the common mechanisms, but these are not the only mechanisms. There are those where an organ will be not induced so that it can form. Such mechanisms of failure of induction will give you absence abnormalities. It means that the organ will completely be absent. So that is failed induction. An organ is not induced to form. There's no molecular induction for the formation of particular organ. So you'll have absence malformations. The common term we use for absence is agenesis. So you can talk of renal agenesis, limb agenesis, and the like. Agenesis means fail to form. Sometimes you may have persistence of an embryonic structure. This applies for scenarios where the embryonic structure is supposed to disappear, yet it does not disappear. For example, you know that the notochord is supposed to disappear. So if it doesn't, then what happens? The yolk sac, or rather the vitelline duct, is supposed to disappear. If it doesn't, what happens? Primitive streak is supposed to disappear. If these embryonic structures persist, you can have a congenital anomaly. Some malformations are due to inadequate or failed cellular migration. Cells are supposed to migrate from point A to point B. So they may migrate, but do not complete their migration path, or they may fail to migrate completely. Some examples we've given in the past with regard to this mechanism would be things like neurocrest, which are supposed to migrate. So if they don't migrate, what happens? You did an assignment on neurulation and neurocrest. So perhaps you're familiar with that. If you aren't, then I can give another example. During gametogenesis, we agreed that the primordial germ cells are supposed to migrate from the yolk sac to the developing gonad. So if they do not reach there, I gave you some scenarios. If there is no primordial germ cell in the gonad, then you get gonadal dysgenesis. If primordial germ cells get lost, they become ectopic, they can give you teratomas. Those are abnormalities of migration. You can have scenarios where the tissues have over-migrated. And a good example is the development of the thyroid gland. Thyroid gland usually comes from the tongue, you don't know that. And then it migrates downwards to come in front of the trachea, lower down in the neck. Sometimes the thyroid gland may not migrate adequately. And so that applies to point number 3. The thyroid gland will be high up in the neck. It could be even in the tongue. But sometimes it can over-migrate. And so that applies to point number 4 there. When it over-migrates, could be now in the thorax. So it will give you an ectopic organ. You can have abnormalities due to developmental arrest. It means that the developmental process is going on, but it gets arrested. Right. In developmental arrest, you'll have a structure, yes, but the structure will be incompletely developed, as opposed to absence anomalies, where the structure is not there completely. So these are some of the mechanisms. Still, you can have abnormalities which are due to incomplete or partial separation. This applies to scenarios where structures are supposed to separate. You need to have a structure that's supposed to separate. Now, if they don't separate, what happens? A good example here would be perhaps in the development of the digits, where the fingers are supposed to separate. So if they don't, then it means you have fusion. You can also have abnormalities to defective septation. A septum is supposed to form that separate some chambers. A good example here would be in the heart. The heart is initially just one chamber, but then 4 chambers form, 2 atria, 2 ventricles. If that process of separation does not occur well, then you'll have abnormal communication between the heart chambers. There are scenarios where you can have failed or inadequate or excess tissue resorption. There's some tissues that need to be resorbed during development. And a good example would be the development of the tongue. The tongue at some point is just held down to the floor of the mouth. Some resorption occurs that frees the tongue. If that doesn't happen, then your tongue will be held down to the floor of the mouth, and that's what we call tongue tie. There are scenarios where 2 structures are supposed to fuse or merge. Maybe one from the right, one from the left. If they don't fuse or merge, then you're going to get a defect in the middle. And a good example would be the development of the palate, where the right and the left palatal shelf grow towards the center and fuse. If that doesn't happen, then you get a cleft palate. Even the tongue, by the way, right and left tongue develop separately, then they fuse. If that doesn't happen, then you're going to get a tongue that is split, what we call bifid tongue, like the one of snakes. Or sometimes you may have abnormal union. 2 structures are supposed to unite, but they don't unite appropriately. So you get an abnormal union. They have united, yes, but not in a very symmetrical manner. Right, so these are some of the common mechanisms that explain congenital anomalies. The list is not exhaustive. I've just chosen to give you some common ones. I will now take you through examples of congenital anomalies. The aim of this session is not really for you to remember these examples, but to trigger your mind to the fact that they can actually do occur. And I've tried to select some common ones for each of the systems. We talked about conjoined twins, of course. This is based on twinning. We said that if they are joined in the thorax, we call them thoracopegus. Those are craniopegus. These are omphalopegus. The mechanisms here would be incomplete separation. That's the mechanism behind conjoined twins. They are incompletely separated. You can have abnormalities of the limbs, like the one you look at that is called clubfoot. We may not want to talk about the mechanisms of clubfoot. The one you're seeing here, I don't know whether you can pick it easily, but this guy has extra fingers. There are 6 instead of 5. That's what we call polydactyly. In this other one, we can definitely see that there are 2 fingers which are fused. So this is where now there is failed separation. That is what we call syndactyly. Fused digits, syndactyly. Extra digit, polydactyly. The dactyls refer to the digits. Can have abnormalities that affect the central nervous system. The one I asked you earlier are the neurotube defects. An example of neurotube defects is the one projected there, the spina bifida. This is the cystic type. And you want to see what is within the cyst. So this could be the meningocele or myelomeningocele. This is what we call hydrocephaly. There's a lot of water within the fluid cavities of the central nervous system. It makes the brain to bulge this size. The problem could just be that there is some blockage so that the cerebrospinal fluid is not flowing appropriately. This is what we call encephalocele. Encephalocele is similar to meningocele. The only difference is their site. So in the spina bifida meningocele down there, it's affecting the spinal canal. Encephalocele affects the cranium. This type of encephalocele is what you will call occipital encephalocele because occurring in the occipital region, as opposed to frontal encephalocele that would happen on this other side. So remember, neurotic defects are due to defective closure of the neural arc. Defective closure of the neural arc, which means two structures are supposed to fuse, they don't fuse. You can have some abnormalities in the face, and the kid you're seeing there has a cleft both in the palate as well as in the upper lip. This is failure of fusion. The one you're seeing here has something holding the tongue down. So this is due to incomplete tissue resorption. We call it tongue tie, or by that name you're seeing there, ankyloglossia. This one has a very small mandible. The lower jaw is reduced significantly. Could be part of a syndrome. This one actually, it's part of a syndrome. But if you just focus on the mandible itself, a very small mandible will be called micrognathia. But this is part of a syndrome. Some abnormalities in the urinary system. You can have scenarios where the kidney is not where it's supposed to be. Maybe it's in the pelvis. So if it's in the pelvis, then you call it pelvic ectopic kidney. The term ectopic means something is not where it's supposed to be. So these are abnormalities of migration. The kidney is supposed to migrate from the pelvis up to the abdomen. So if this one doesn't, then you get ectopic kidney. In this case, it is ectopic in the pelvis. We call it pelvic ectopic kidney. These ones, the right and the left kidney, have abnormally merged. Told you can have abnormalities of abnormal fusion. The right and left kidney has fused here. We call it horseshoe kidney. Here, the anterior abdominal wall is not well developed, and the bladder wall also is not well developed. The urinary bladder is exposed. And you may not believe, but this is a boy child. So even the external genitalia is affected. We call this extrophy of the urinary bladder. Can have abnormalities that affect the male external genitalia, like the urethra is not opening at the tip of the penis, opening somewhere down. We call that hypospadia. It could be that you look at this genitalia and you're wondering, are we male here? Are we female here? That's what we call ambiguous genitalia. You may not believe that this was male because their test is here. You can have scenarios where one of the testes is not in the scrotum. You can call it undescended testis, or we commonly call it cryptorchidism. Just like for male genitalia, you can also have abnormalities that affect the female genitalia. And most of these would be affecting the uterus, fallopian tube, cervix complex. Collectively, we call them Mullerian duct malformations. Could be double uterus, like the one you see up there, double cervix, double vagina, and perhaps double husband. Could be where there's only one uterine horn. It could be a septum in the uterus and the like. Mullerian duct malformations. Multiple mechanisms. Failure of fusion, or partial fusion, or incomplete tissue resorption, or agenesis of one side will give you these ones. Can also have ambiguous genitalia, where the gender was meant to be female, like in this one. These are actually labia majora, and so there's no testis. This child actually had an ovary, but something is masquerading as the clitoris there, which is so prominent, almost being called a penis. This is still ambiguous genitalia. Can have malformations that affect the anterior abdominal wall. The common is where there are no muscles in the anterior abdominal wall. So this is just very hypoplastic anterior abdominal wall. We call this prone belly syndrome. It occurs as a syndrome. That means there'll be some other anomalies associated with the prone belly, not just hypoplasia of the anterior abdominal wall. This one is quite common, where the umbilicus is a bit prominent. So common that you may not even recognize it as a congenital anomaly, but that is umbilical hernia. It could be congenital or acquired, actually. You can have scenarios where the intestines are actually out, and we call that gastroschisis. Malformations involving the GIT, you can have what we call Encephalocele, like this one. This is due to failed migration, but you'll be taught more about it. There's some time in development when the intestines are actually outside the body, and that's normal. That happens on the 6th week of development. The intestines are supposed to go back into the abdomen by around the 10th week of development. If that doesn't happen, then you get Encephalocele. There are other mechanisms of Encephalocele though. This is where now you have intestines on one, small intestine on one side, large intestine on the other side. We call this malrotation. I didn't give you that as one of the mechanisms. You can still add it on your list. Abnormal rotation. The intestines are supposed to rotate. If they rotate abnormally, then this is the picture you get. The normal one is where you have the large gut going round the small gut. Small gut is at the center, large gut is around like this. So this one, small gut is on the right, large gut is on the left. Malrotation. The one you're seeing here is what we call Marquez diverticulum. We've mentioned it before. It is due to persistence of an embryonic structure. In this case, persistence of the vitelline duct. You can have abnormalities regarding the pyloric sphincter. May not be so congenital though, tends to appear, usually diagnosed not at birth, but maybe like 2 months after birth, 8 weeks. So the debate whether we should consider this one congenital. Either way, let me put it here because we still see it in the pediatric population. Pyloric stenosis is the thickening of the pyloric sphincter. And so this child cannot really take food from the stomach to the small intestine. Food accumulates here and they'll tend to vomit it a lot. You can have a scenario where the duodenum is not patent. Blockage of any tubular structure could be termed as atresia. The term atresia means blocked. The term stenosis means narrow. So if a part of a gut is narrowed, then we call it stenosis. If a part of a gut is blocked, then we call it atresia. In this case, it's the duodenum, so we can call it duodenal atresia. There is what we call a ganglionic megacolon. This is the absence of neurons in some segments of the large gut due to abnormality of migration of neural cells. Let's talk about the ones affecting the respiratory system. You can have abnormal communication between the trachea and the esophagus. We call this Trichosophagia Fistula. You can imagine this child when they breastfeed, maybe food goes to the airways, they can easily choke and die actually. Or like in the third case, this child cannot swallow appropriately. So they can't feed. They have to undergo surgery. These are due to defective separation. The trachea and the esophagus usually come from a common embryonic structure. Now, if they don't effectively separate, you're going to get Trichosophagia fistula. The one to your right is showing you a scenario where one of the lungs is absent, pulmonary agenesis. In the cardiovascular system, you can have defective separation, so you get what we call septal defects. Could have ventricular septal defect. You can have atrial septal defect. These are the ones we call a hole in the heart. Some of them can occur as part of a syndrome. Teratology of Fallot is actually a syndrome of 4 things. And we talk about those 4 things much later. You can have abnormality of narrowing of the aorta. We call that coarctation of the aorta. Relatively common malformations, actually. In the skin, of course, you are aware about albinism. You're also aware about vitiligo. You may not be aware about this one, but you can have excess keratinization. Then you call it ichthyosis. Okay, the ones in the breast, we can finish with these ones. You can have absence of the breast. What you're seeing is not the back of this lady, but actually the front of that lady. The breasts are absent. We call that a mastia. Or you can have a nipple that is inwards. This is also a bit common, actually. You just call it inverted nipple. You can have someone with extra breast. The ones in the thorax are there, but the others up there. We call that polymastia. Extra breast is not necessarily advantageous. And sasa moja ni ya mtoto na moja ni ya mzee. Great. I've taken you through common morphological defects. What are the causes of congenital anomalies? It might interest you that in as much as there are many congenital abnormalities, close to half of these malformations, we actually don't know their cause. Or rather, let me say, a cause has not been identified. In about 18% of the malformations, there are non-genetic factors that have been described. In about 7% of the malformations, there are non-environmental factors which have been described. Now, the last group is important, that in about 25% of the cases, the causes are multifactorial. When you talk of multifactorial, it means that there is genetic predisposition and environmental factors working together. That's very important for you to know. That you may have a genetic predisposition, but if there is no environmental exposure, then you may not have that defect. Or you may have an environmental exposure, but if there is no genetic predisposition, then you may not have a congenital anomaly. I would therefore ask you a question that I want you to respond in the chat. Based on this concept that I've given you, what percentage of congenital anomalies can be intentionally prevented? What percentage of congenital anomalies can be intentionally prevented based on these numbers I've given you? So I just want to write the percentage on the chart. Carry on. I'm waiting for you people. I can only see results for 4 people only.
Excuse me.
Yes.
I can't even see the question.
Yeah, I haven't projected the question. I asked the question.
Oh.
So, Roylin, you are the first person to get it right. Do you want to tell us how you got yours?
I think I just wrote that because you saw like this multifactorial actually can be avoided, plus this environmental. If you keep an safe environment and you avoid like this, yeah, that's what I think.
Okay, so your response was 32%, and you're right. Huh? Yes, so those who have written 32%, they're right. Those who have said 7%, you're not right. Those who have said 25 and 50, now you know why you're wrong. So only 4 people have gotten it. Now, let's look at genetic causes of birth defects. How do we classify genetic causes of birth defects? Birth defects, genetic cause of birth defects could be due to chromosomal defects, or they could be due to gene mutations. The ones which are due to chromosomal defects can be due to numerical chromosomal disorder. And the term we gave for that is aneuploidy. You can have trisomies like trisomy 21, Down syndrome, trisomy 18, Patau, trisomy 13, or rather, trisomy 18 is Edward, trisomy 13 is Patau. You can have 47XXY, Klinefelter's. Or you can have monosomies like 45X0 for Turner syndrome. Apart from numerical chromosomal disorders, you can also have structural abnormalities of the chromosome. The chromosomal number is normal, but the structure of the chromosome is abnormal. I will just highlight for you some two abnormalities here. You can check them later. There's what we call fragile X syndrome. So it has structural abnormalities of the X chromosome. You can also have what we call Cri-du-Chat. Cri-du-Chat means in English, cry like a cat. You can check on what it really entails. But those are due to abnormality of the structure of a chromosome, not number. The number of chromosomes is normal. Then on the other side, we can have gene mutations. What's mutation? Mutation is alteration in the base sequence of a gene. Remember, bases are those things like cytosine, thymine, guanine, and adenine. Usually there's a particular order in which the bases should be for each gene. Remember, gene is a sequence that codes for a single protein. The sequence of bases in the DNA that codes for a single protein is a gene. So if you have alteration in the base sequence of a gene, we call that mutations. We classify mutations based on the chromosome they involved. If they involve the first 22 chromosomes, then we call them autosomal. If they involve the 23rd chromosome, then we call them sex-linked. If they are sex-linked, then you want to know whether it is linked to the X chromosome or it is linked to the Y chromosome. If it is linked to the X chromosome, then you call it X-linked. If it is linked to the Y chromosome, then we call it Y-linked. You can also have gene mutations based on whether the mutation will definitely show as long as it's there. We call that dominant. Or whether the mutation will only show if you inherit it from both of your parents, and we call that recessive. Now, in terms of how we classify gene mutations, we combine this concept with this concept. And so you can have something like autosomal dominant. It means that this mutation will definitely show, or rather express itself phenotypically, and that the mutation involves one of the first 22. You can also have autosomal recessive, which means it involves one of the first 22 chromosomes, but you need to inherit this defect from both parents for it to show. Could be X-linked, which means that it is linked to the X chromosome, but you need to be recessive you need to inherit from both parents for it to show. If you're male, the scenario is a bit different. Let me ask you, if there is X-linked recessive disorder, or rather, let me put it this way, X-linked recessive disorders, they'll be more common in which gender? Male or female? And maybe I want to know the why. Anyone, you can just unmute yourself and say something.
I think it will be more common in female because the female, they have like two X's. Compared to a male, it won't be too much exaggerated because at least they have like one Y and one X.
Okay. Okay, someone else?
I disagree.
Okay, what's your opinion?
It often occurs in males because they only have one X chromosome. A single gene on that X chromosome will cause the disease. The Y chromosome will not. So they have a single X chromosome. That's why it mostly occurs in males.
All right, and I agree with you, Jamutai, that when you have an X-linked recessive disorder, it will affect males more than females. The reason is, you see, if it is recessive, males have only one X chromosome. So whether it's recessive or dominant, it will always show. Females have two X chromosomes. So if a disorder is recessive, it will not manifest clinically. The person must inherit from both parents for it to show. But for male, as long as you've inherited it, it will show. It doesn't matter. For the male, it won't be recessive or dominant. They will always show because they only have one X chromosome. So 70% of X-linked disorders actually occur in males. Examples of autosomal dominant malformations include things like these. You may not know what's happening here, but look at the, this is the sclera, and then this is the iris. Now look at that iris, very short. Then the pupil is so big. This is a reflection, forget about that. But look at the size of the iris. The size of the pupil. Very big because the iris is very small. Aniridia is absence of the iris. This guy is too short for age. This is achondroplasia, also autosomal dominant. If you have the gene, it will show. Autosomal recessive disorders include things like this one. This is what we call phocomelia. Absence of the intermediates. The intermediates here being arm and forearm. So the hand is attached to the trunk, as you can see. Albinism is also autosomal recessive disorder. You must inherit it from both parents. X-linked recessive disorders include things like ichthyosis. This is hyperkeratinization. Or even, okay, you may not know that one, but that's hemophilia. You see there's a bleeding tendency. So these ones will occur more in males. Right, those are genetic disorders. Let's talk about environmental factors. Environmental factors could be mechanical factors, like let's say amniotic band syndrome, or some oligohydramnions during pregnancy and the like. Could be chemical factors. There's a drug that this woman took during pregnancy or something. Could be physical factors like radiation. Or it could be infections. The mother got some infections like rubella infection, cytomegalovirus, CMV infection. You'll be told about some infections that cause congenital anomalies. We call them torches. You can surf at your own time, TORCH. So those torch infections, they cause congenital anomalies. I have a question for you. This one is coming to you on the poll. Okay, so it's projected on the poll for you. You have a minute for that question. Answer it on the poll. One person hasn't responded, but I think I'll close it. So most of you have gotten it right. When you look at environmental factors that cause congenital anomalies, there are some things which are important to highlight. One of them is that there's a critical period of development within which there is a higher likelihood of them causing an anomaly. And that critical period is the period of organogenesis. The period of organogenesis, if you remember, spans from the 3rd to the 8th week of development. If these environmental factors act earlier than 3rd week, most likely they just lead to fetal demise or embryonic demise and termination of the pregnancy. So that's not a congenital defect. If they manifest, or rather if they are exerted after the embryonic period, most likely they just affect function. But if they act during the embryonic period of development, then they have a likelihood of causing a congenital defect. As we had mentioned earlier, environmental factors will also tend to act where there is genetic susceptibility. We mentioned that 25% of anomalies are actually multifactorial. The dosage of the environmental factor is also a critical thing to consider. If a particular fetus is exposed to a lot of this environmental factor, then you increase the chance of causation of birth defects. What are the consequences of exposure to a teratogen? You might be surprised that there's a whole list of possible consequences. One of the possible consequences is that if a mother who is pregnant is exposed to a teratogen, it can actually terminate the pregnancy. The baby dies. It may lead to a congenital malformation. So in the first category, most likely if it happens in the first 3 weeks of pregnancy, and in the second category, if it happens during the embryonic period of development. Sometimes not death, the baby will survive, except the baby will grow slowly compared to the age of the pregnancy, and that's what we call IUGR. Instead of using the term retardation, you can use the term restriction, intrauterine growth restriction. So the baby is there, but small for the age. You expect this baby to be, let's say the baby is at 36 weeks, but the weight of this baby is still maybe less than 1.5 kgs. So feel this is small. You can just have functional defects in the newborn, like CNS functionalities, maybe there are abnormal reflexes and the like. Interestingly, many times, the outcome is normal. So it doesn't mean that if you are pregnant and peradventure you got exposed to a teratogen, that automatically it is catastrophe. No. Most of the time, actually, it will just be normal. You'll be surprised how mothers who are pregnant are exposed to radiation each and every time, but the babies are fine. Okay, how do we diagnose congenital anomalies prenatally? We can diagnose congenital anomaly using some sampling techniques. We take samples. The sampling techniques tend to be invasive because you have to introduce a needle to collect the sample. That sample can be obtained from the amniotic fluid, and that's what you call amniocentesis. We talked about it. It can be obtained from the chorionic villus, and we call that chorionic villus sampling. We also talked about that last time. It can be obtained from the umbilical cord of the fetus, and we call that percutaneous cordoscentesis. This is still ultrasound guided. The blood in the umbilical cord is definitely the blood of the fetus. So just get a sample from the blood of the fetus. The ones which are not invasive are imaging modalities. There are two imaging modalities that are recognized and recommended to scan for congenital malformations. Ultrasound is the commonest one. When you're sending a mother for an anomaly scan, then there's a particular time period that this should be done. Usually around the 20th week of gestation, that's the best time to do an anomaly scan. I'm not saying that's the best time to do ultrasound scan for obstetric, no. I'm saying if your interest is to find out whether there are congenital malformations, then the best time is 20 weeks. You can do ultrasound scan anytime for any other thing, not a big deal. But if you want to know whether the organs are well formed, then the best time to wait, the best time to do it is at least from 20 weeks onwards. Because before that, there are some things that have not fully developed well, and you can describe them as abnormalities, yet they are normal developmental processes. But from 20 weeks, we expect most, if not all, the organs to have actually reached their morphological picture that they'll do similar to what they'll be postnatally. Few of the times we'll do obstetric MRI. It is still safe and recommended. The problem is that it's very expensive, tedious, cumbersome. Very few people know how to read it. So not all the time will you be doing obstetric MRI. There are very few patients that you'll send for obstetric MRI, and especially where ultrasound cannot really give a conclusion. All in all, ultrasound is the first line. You can even do 3 ultrasounds and not a single MRI. Because it's cheap, it's easy to use, it's available everywhere. You can recheck anytime. You can do dynamic studies easily. Great. So this marks the end. Okay, the image you're seeing there is for obstetric MRI as opposed to the previous one. This is ultrasound. This is an ultrasound image. This is obstetric MRI. Maybe you're looking at them and you don't see the difference. It's okay. The intention was not for you to see the difference. I think that marks the end of the series of lectures we've been having on general embryology. So if you have a question, you can ask.